Değerli katılımcılar günaydın. Kongremizin son oturumu. Ondan dolayı muhtemelen salonda çok az arkadaşımız var. Bu konferansta Uluslararası Pankreas Çalışma Grubu Genel Sekreteri Profesör Giovanni Marchegiani iki konferans verecek bize. Giovanni şu an Padova Üniversitesi'nde HPB ve transplantasyon ünitesinde çalışıyor. Daha öncesinde Verona Üniversitesi'ndeydi. Kısa bir zaman önce Padova'ya başladı. Bizi kırmayarak çok yoğun programlar içerisinde gece saat 2'de burada oldu. Şimdi iki konferans ard arda verecek. Çok keyifle dinleyeceğimizi düşünüyoruz. İlk oturumunda pankreas cerrahisini tanımlamada güncel durum, gelecekte nelere ihtiyaç duyacağız, bundan bahsedeceğiz. So, welcome all today's this conference. The Professor Giovanni Marchegiani will give some lecture about pancreatic fistula, its definition, new definition. And Giovanni, you know, the secretary of International Pancreas Study Group, and now he is working in Padova University HPB and Transplantation Center. We can start, Giovanni.
Thank you. Thank you, Professor Kerem. It's really a pleasure to be here. And I would like to extend my gratitude to all the friends that I have here whenever I come to Turkey. So the first talk today will be about definition in pancreatic surgery. And as Professor Kerem introduced me and said, most of them actually rely to the International Study Group for Pancreatic Surgery, which is, you will see, basically the study group that was founded by my mentor and I would say father, Claudio Bassi, who unfortunately passed away this year. So I think that if I have a single slide to wrap up what is it about, to define something in surgery, it's probably a matter of agreement. And we know how this is actually difficult, not only in pancreatic surgery, but probably in life, which is agree upon on something, even when this seems to be easy, seems to be, I would say, possibly not difficult to assess. But what if I tell you that in pancreatic surgery, 20 years ago, more than 25 different definitions of fistula existed. So maybe now we laugh about it. It's like funny, but it wasn't. And the situation was not only within Turkey or Italy or Europe, wherever in the world, like a bubble tower. It was impossible for surgeons to compare the outcomes and to define how to reduce pancreatic fistula. So again, this is a key concept whenever we come to definition, to standardize upon something, so to make things of the same type all have the same basic features. And in surgery, this concept brings innovation. It provides a structured method and reliable data. This, of course, saves times for studies and also disseminate groundbreaking ideas like the one on fistula about surgical topic. And once again, this was the mission of the International Study Group for Pancreatic Surgery. I have here Professor Mert Erkan from Istanbul, who is a brand new member of it. So it's really like a society that still feels young and provides definition and grading of complication. Being this, I would say, most famous and most common one, you probably all know about the definition of pancreatic fistula. The original one was drafted in 2005, and it's in the books. But what I am extremely always happy about it is that the original paper is the most cited paper in the history of gastrointestinal surgery. So it really means that not only the definition, which you all know, but only the threefold grading that has changed during the year because now, of course, we know that all the procedures that we might do because of a fistula, particularly angiography, endoscopy, or percutaneously, they now all pertain to the B fistula rather than a C fistula, where only reoperation, death, or sepsis takes place, is still and will be the one and only definition that is used for data comparison and to increase the knowledge about this complication. And I truly think that this is the most important value of this definition. So it's not, okay, we have a definition, it's starting a journey towards standardization thanks to this definition and grading. And I will show you why. Thanks to this definition, we are even now shifting from the concept of predicting a fistula to mitigating a fistula, which means depending on the moment where we are, we can not only predict a complication, but also start an early management of this given complication itself. Because of course, the more we get closer to the fistula, the more we are accurate in predicting it. But the problem is whether it's too late, because the fistula is already there. So we also need other tools, not only for the early prediction, but as I said, also for the mitigation of this given complication. Because unfortunately, the more we know about fistula, the more we understand that it's not all about the fistula. We have now other pancreas-specific complications playing a role in the general outcome of our patient. And when they come together, it's actually difficult to understand where is the fistula, where is the acute pancreatitis, where is acute pancreatitis in the very first days of post-op. So to, again, understand what's going on, we need to have better definition. And we start to have this in the operating room. 10 years ago, this score came out. It was the first externally validated score, again, during the surgery to define the risk of a given fistula. So for those who doesn't know that, it's called fistula risk score. You see that you have here some factors, here, like texture, pathology, duct size, and blood loss as a surrogate of how difficult your surgery is. And when they come together, they finally have, you see, a score in numbers that provides us a scale of the likelihood of having a fistula or not. And you see that at the end, in bottom line, you have risk zones from very low, meaning negligible, to intermediate, to finally high risk, that define what can be done in the operating room because of the specific risk of your patient, of your fistula. In 2021, also the ISGPS provided probably an even more simple score, because you see here only soft or hard and duct size provides you a 4-class A, B, C, D of risk, where, for example, you see here that when the pancreas is soft and the duct is small, you have a very high risk of developing a fistula, but the concept remained the same. Predicting a fistula already in the operating room before performing your pancreatic anastomosis. And look where we finally landed thanks to this definition. This was a trial we did in Italy 4 years ago, only on the very high risk pancreas. So we didn't put any attention whenever the pancreas was hard or the duct was big. We all know that those pancreas are very low risk, but only in the very high risk we ran this randomized controlled trial published in JAMA Surgery, defining that pancreatic jejunostomy rather than pancreogastrostomy had a lower likelihood of developing additional complication whenever the anastomosis was protected with a stent, which was the real game changer in decreasing the complication rate and also the clavia-endindo additional burden of a fistula. Again, this was done thanks to a definition Without a definition, this trial was impossible to be performed. So we landed to this, I would say, landmark publication, again, thanks to a standardized definition and graded method. And look what we have now. This comes from our Dutch friends. You heard Mark Besselink yesterday talking virtually to this very nice conference. And this is a trial that they did, again, starting from a definition. They even defined an app, and this provides you an algorithm that basically tells you what should be done whenever you have a patient developing symptoms, developing fevers. So the app tells you better to provide a CT scan or start an antibiotic. Once again, thanks to this tool, you see that in the entire country of the Netherlands, this led to a decrease in the mortality, morbidity, and also the overall complication rate of pancreatic surgery. So again, look all the journey that has been done since the very beginning to the modern days. Again, thanks to the definition of the year 2005. So I don't want you to get bored. It's the last day of your conference. So I just want to mention that this is just one of the multiple definitions provided by the ISGPS. Imagine that, of course, now every given complication has a definition and a grading provided by the ISGPS, namely delayed gastric emptying, which is actually a very important entity because the literature about it is not so rich, I would say. Biliary fistula, which is done together with the International Study Group on Liver Surgery. And we're gonna get there, post-pancreatectomy hemorrhage, which still is a very harmful complication, and finally even chyle leak. So if you're not familiar with these complications, my suggestion is to go through the original definition and grading from the ISGPS and starting to assess your complication based on this, because we as pancreatic surgery, we all have complication and we always have complication. If you don't have any complication, it means that you do not operate on a pancreas. That's my probably most important take-home message. But then I have a scenario for you, a clinical scenario for you. So we are now on POD1 after a Whipple. Everything seems to be fine, but there is a problem. In this patient, the serum in the amylase is high. And the patient is still okay, but you have the feeling that something is not going well. Is there a meaning in having high amylase on POD1 after a Whipple? Probably yes. And to tell you what I feel about this, I take this metaphor of the galaxy, of all the stellar system we are all in. So we all know that it all was created from a Big Bang, from an original, of all the species, of all the stars, which is of course a moment very difficult to be explored in astronomy. But if we are able to explore that very first moment, then we understand what has been done afterwards. And this is exactly what happens after a Whipple. During a postoperative course, if we are able to explore the origin of a complicated postoperative course, then we are able to understand all the possible complications taking place afterwards. And we feel that we probably found that Big Bang, that sparkle, by defining post-operative acute pancreatitis, which is a very early phenomenon. There are even animal models attesting that this is an ischemia driving complication that happens already in the OR, probably right after you cut the pancreas. So it's very difficult to explore, but it exists, and I will try to convince you about that, not in the shape of a true pancreatitis, but in most of the cases as this, which is an elevation of the amylase in your serum within the first 48 hours. So if you check your amylase on POD1 and POD2, you would be able to label this patient as a patient who is at higher risk of eventually developing acute pancreatitis. Then, of course, as for the other ISGPS definition and grading, to have a properly defined grade B acute pancreatitis, of course you need to have a clinically relevant change in the management, and radiological features of this pancreatitis as in the medical counterparts. And finally, whenever you have a more severe acute pancreatitis, then we're going to define this as a grade C complication, as for any other ISGPS complication. Again, why is this very important? Because if we look at this funnel that starts even before surgery, goes into the operating room, and then in the postoperative course, of course, the closer we get to the fistula, as I said before, the more we are accurate. But where are we with acute pancreatitis? We are here in the very early phase after surgery, POD1, POD2, POD3. So this is extremely early. This is when we can still do something, not to prevent, but to mitigate a fistula, which is becoming clinically relevant. So that's why in these very first hours, you should check your drain fluid amylase, you have to check your serum, whether you have amylase or not, and your CRP, because with these very, I would say, cheap and reliable tools, you can define whether an hyperamylasemia, whether an acute pancreatitis is taking place. And look what happens whenever you have this factor. We're going to call this POH, which means high amylase in the serum. So this is a situation where you have no POH. You see, you remember the risk classes I showed you before? According to the FRS, you see that the risk of fistula depends on the fistula risk score, right? But if you have POH, then the risk classes becomes absolutely irrelevant. Why is that? Because we are now after surgery. We are now on POD1, on POD2, so we're getting closer to the fistula. So of course we are more accurate in predicting whether the fistula is happening or not. So once again, the message is check your amylase. It's very cheap, it's very reliable, and in this way you will be way more accurate in defining the presence of a fistula. Because it's not only about the fistula. I told you before, all these complications, they tend to aggregate. They come together, and you see that POH has a relevant implication not only on fistula but also on additional comorbidities such as DGE, PPH, and all the clavia-dindo additional complications that in pancreatic surgery they tend to occur all together. So now your question could be, okay, Giovanni, but does this really matter? Because you started with a definition, which by definition probably is not perfect. So I want to show you before publication, this is a spoiler then, alert, of how we did validate this ISGPS classification. And this was actually very important, because without this, without a validation, a definition remains an expert opinion. So there has been a lot of fight in the ISGPS at the time of the definition, and finally I provide you now the evidence that we need to see whether this is a good definition or not. So on a total of 2,300 of patients enrolled, we have, and this is the first time that I show this data, that 21% of these patients, so 1 out of 5 of your Whipple will develop this POH. So this is extremely relevant, and I would say also extremely frequent in your practice. Then of these, 7% roughly will develop a clinically relevant acute pancreatitis. So it's not so common, I would say, but it's, I would say, absolutely frequent to have acute pancreatitis after a pancreatic resection. And if you are wondering whether most of them are B or C, well, luckily, most of them are grade B, and only 1%, I would say, luckily, only 1% will develop a grade C acute pancreatitis, meaning that this patient has been reoperated or died because of this acute pancreatitis. So, what do we need in the definition, as I said, is a validation. So, of course, we just didn't want to define the incidence and the grading of acute pancreatitis, but also, as you can see, whether the system which is POH, grade B, and grade C is valid. And you see that we wanted to test this according to parameters that are outside the definition, because of course otherwise you're not validating the definition itself. So we considered ICU stay, the readmission, and the length of hospital stay, and we found that there is, as you see, an increase for all these three factors when you go through POH, grade B PPAP, and grade C PPAP once again. And I just want to underline that still there are patients, as you can see here, that have an ICU admission whenever POH is there. So you might wonder, why is that? You said POH is only in the serum, is only something that, you know, tend to occur on POD1 or 2, but still, it can be the target, it can be the only way that we have to define that this complication will eventually evolve in the most, I would say, dreadful postoperative course. So once again, check your amylase and label this patient at higher risk of developing a given complication. So what are the take-home message at the end of this journey that we did together regarding definition and standards? So the first is that by definition, sorry for repeating, definitions are arbitrary. So when they start, there is a consensus, which means expert opinion. You have no evidence at the beginning. Okay, in 2005, Claudio Bassi and his friends didn't have any evidence for fistula. They just had to define what fistula was, and then they started to build evidence according to that. So again, by definition, definitions are not perfect. By definition, I would say, but they pave the way for prospective and validation study that will eventually build up new evidence to reach higher standards of care, as the one that we have now regarding the fistula. We wouldn't have had these standards without a definition and a grading. And finally, to answer to the question that I was asked to come here, what do we need in the future? So those are 3 examples of new definitions that will be eventually released. So this is a spoiler, okay? So probably the SGPS would be upset to me, but I want to share this with you. So there will be soon a minimally invasive pancreatic surgery difficulty score, so a way to define who should perform minimally invasive pancreatic surgery and with which standards, which is absolutely lacking right now in the literature. There will be a definition and a grading of postoperative diarrhea, because the more now we do arterial resection, we do divestment, we do artery first, we know that postoperative diarrhea is a very relevant and severe phenomenon. So that will be another definition and grading. And finally, I was mentioning before, with the development of neoadjuvant chemotherapy, we are now way more aggressive on the arteries. So also a definition and a classification of arterial resection and divestment will be soon provided by the International Study Group of Pancreatic Surgery. So stay tuned for more, because then all these studies will require a validation. So I'm already welcome you on board, whether you will be part to this project. So this is the final slides of my talk. As Professor Cerr said, I'm now running the pancreas program in Padova, which is in Italy by far the most important university for pancreas, because it's where the German anatomist Wirsung for the first time defined the duct named after him on a turkey. And at the beginning, the anatomist Johannes Wirsung had no idea what it was, so he sent out to his fellow anatomists a copper plate of what he found, and no one had a clue of what it was. So this was probably one of the first pancreatic mystery, and he was actually eventually murdered by one of his pupils, claiming that probably the duct was not discovered by Wirsung itself. So there is also, I would say, a thriller, you know, behind the history of the pancreas. So this is probably one of the multiple reasons that you should probably come and visit this wonderful city. This is the old anatomical theater, the oldest in Europe, which is pretty amazing. So besides that, there is not only HPB surgery, there is also a lot of history, so you're all welcome to visit us in the biggest HPB center that we have in North Italy. Thank you very much.
Giovanni, thank you. It is really great presentation. First of all, as a Turkish HPB society, one more times we can say we are sorry for Professor Bassi. He is founder of the International Pancreatic Study Group. Also, he has many contributions to the pancreatic surgery. And really, one more time, we want to say to the sorry for this. It's so big loss. So we can take some question from audience. Mert.
Giovanni, excellent talk as usual. Two questions. First, many of us put holding stitches to the upper and lower margin of the pancreas, and sometimes in a long operation you see that the pancreas is getting slightly different color than what is behind those sutures. Do you think that would impact on this thing? It doesn't happen in every patient, but sometimes you see you might even do a re-resection of that segment if you feel uncomfortable. This is my first question. The second thing is, when you are measuring the postoperative drain amylase, do you think it would make sense to standardize whether you wash the abdomen after you finish resection with a certain amount of saline, because some of us do that and some of us don't, because during the operation, before you suture the duct into jejunum or stomach, that juice is continuously flowing into the abdomen. So the first postoperative day amylase is not influenced only by what is leaking after you finish the anastomosis, but also what was there left and not washed perhaps away if you do not standardize this. Do you think it would make sense to also standardize this point?
Thank you, Mert. Those are actually great points. So my disclosure is that Mert and I are good friends since many, many years. And so we have this discussion usually during nice dinners in Istanbul, as we did a couple of months ago. So starting with the first question that you ask, this observation is actually very relevant. And before coming to the definition, we had, but not only myself, the entire team who worked at the acute pancreatitis, we had to run several studies. For example, we also did indocyanine green studies about the pancreatic stump. And we found, as you said, because that's my practice as well, I usually put stitches on both edges that I also use then to suture the dunking anastomosis, that yes, it's true, sometimes you have a rim of ischemia that is worrisome, because that's actually where then you put the stitches to do either your Blumgart or your dunking anastomosis. And this phenomena seems to be related to some abnormalities in the anatomy of the vessels. So depending on how the pancreatica magna vein runs, you might have a rim of ischemia or not. So this depends basically on the anatomy of the vessels of the pancreas, and also, and this was actually taught us by Claudio Bassi, my mentor, that you can sometimes want to mobilize the pancreas, because in this way you can better perform either a PGA or a pancreaticogastrostomy, but this mobilization might lead to an increase in this ischemia. And the results were that this acute pancreatitis is actually ischemia related. So it's exactly this problem taking place, and another factor playing a role is the fluid given by the anesthesiologist during the operation. So if you don't do a goal-directed fluid therapy, you have even a more ischemic process taking place. So then you have necrosis, and this could be, it's not only the only factor, one of the factors eventually leading to a leak. So that's a great point. And yes, exactly this. There are also studies on animals, and what could be a take-home message is trying to preserve these small branches of the vein and the artery, making it until the very end of your anastomosis, and always try to invaginate, or even better, to protect your anastomosis with devices like stents whenever the pancreas is fragile, soft, and tends to bleed a lot. So this is not for everyone. There are pancreases, which are extremely rocky, I would say, big duct. In this case, probably you won't have any issue. But in these cases, rather than suture and suture and suture, which at the end it's like butter, you know, it just breaks, right? Is just putting a stent, try to drain it as much as you can, because you know that the fistula will take place. And the only way to define this ischemic process is testing your amylase in the serum on POD 1 and 2. And another trick in these very difficult cases that I learned from my Finnish friends is to start hydrocortisone already in the operating room. So this is a way, and there are 2 trials published in Annals of Surgery attesting that this is actually of value, that defines that this intraoperative administration of hydrocortisone decrease the inflammation that takes place in the OR. So this could be probably another cheap and reliable tool that we can all use in the operating room whenever we have these very risky situations. But this is, I would say, a very good point, of course. Then point number 2, Mert, and this is a wonderful idea of yours. I'm not aware of randomized studies attesting this. I am aware about studies regarding continuous lavage of the anastomosis and the peritoneum. They all failed to define that there is value in this practice, so I'm not in the condition of telling you to either do it or not. I think it's good practice, and I think it's also common sense to wash the abdomen right after a Whipple, because we know that after hours and hours we can have blood, bile, and all like these fluids within the abdomen. But I tell you something, whenever we test the amylase in the drains, this is usually, but depends on the lab, a concentration. So you're right, possibly on POD1 this could be affected, whether you have, let's say, more amylase there, but you also have the peritoneum, which is also able to then reabsorb them. So in the lack of knowledge, I would say that the good practice is to wash very nicely the abdomen at the end and test your amylase, use, of course, on POD1, but then if you're in doubt, also on POD2 and POD3, because we know that the early drain removal policy, they wait until POD3 before removing your drains. But yes, you're right, the crucial one are on POD1, so all the trials we did, they all were after washing the abdomen, trying to decrease the effect of what you described. But again, once again, this has not been done, to my knowledge, in any randomized control trial so far, so it's still experts' opinion.
Başka sorusu olan var mı arkadaşlar? Soru alabilir miyiz? We just keen on the pancreatic texture or pancreatic channel dilated or not for risk of postoperative pancreatic fistula. What do you think about the ERCP or endoscopic stenting? I think we should add this risk factor because so important, especially stenting. What do you think about this?
So, Professor Kerem, this is a great point, and there is no definite answers because, I mean, starting from the trial in the New England Journal of Medicine from the Dutch friends of ours back in 2006, there has been a lot of debate within ERCP and endoscopic stenting. So it depends on the conference, where am I? So if I am within surgeons, I will provide you an answer. If I am within endoscopy, I have to be careful because they are very, you know, I would say jealous about these results. So this is an issue, because we all know that whenever the patient is jaundiced, we need to do a stenting, particularly when the patient comes to referral center from outside. So we don't know from how long the jaundice is there, and we know that this is detrimental, particularly for infectious disease. At the same time, whenever we stent a patient, we know that some horrible complications take place, and these are not only enemy of surgery, but also enemy of our chemotherapy. So in these situations, in this condition, I would say that you should really push your endoscopists to use metal stent. Covered metal stents are way better than plastic ones, and the results are clear in this regard. But possibly, and this is another lesson from our Dutch friends, whenever you can avoid this because you see a patient which is still not that jaundiced, avoiding ERCP and stenting and going for upfront resection is beneficial for the patient. We still have to say that. So I am, I would say, philosophically always in favor of neoadjuvant chemotherapy, But still, there is no evidence that avoiding a stent and going for surgery is detrimental. I still think is the gold standard because there is no evidence that it's not.
Dear Professor, thank you for your excellent presentation. First of all, this is our great honor you are here with us. Thank you for joining our Congress again. My question is about the post-pancreatectomy acute pancreatitis concept. As an HPB surgeon, sincerely, I've recently heard about this, and you mentioned post-pancreatectomy acute pancreatitis is one of the most important cause of post-operative pancreatic fistula. And what do you think about exact pathophysiology about this process? Is it a kind of ischemia after surgery or injury or brutal maneuvers during surgery, and how to avoid?
Thank you very much for your question. And I think that in this way, as surgeons, we have to learn a little bit from our gastroenterology friends. So since Atlanta classification in 1992, they're still fighting about the pathophysiology of the medical acute pancreatitis. So we as surgeons, we only know about the existence of this complication since 2 years. So it's probably too early to have final question. But as I was mentioning before, it's already assessed that there is an ischemic process taking place. So whenever we cut the pancreas at the neck, we have this watershed area that is without a vascularization. So this is probably the first trigger, but then you of course have other factors playing a role. I was mentioning the fluid given by the anesthesiologist. Whenever you have either an overload of fluid or a patient who is too dry, you can have even more ischemic process. Then of course you have pancreas manipulation, and in this we are now studying whether doing robotic Whipple decreases the acute pancreatitis, because of course you have less manipulation of the structure, whether you do it minimally invasive, but still I have no data about this. Those are just ideas for studies to come. I think it's a very intriguing phenomena, and we are now discovering it because now we have the tool to study this phenomenon itself. So once again, we started with the definition, but all the evidence we are now accruing it so far. So probably it's too early to have definite answers.
Okay, thank you, Professor Giovanni, and we can keep on this Congress after 15 minutes, keep coffee break. Okay?
Absolutely.
15 dakika sonra arkadaşlar kahve arasından sonra buluşuyoruz.